بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم.
وأيوب إذ نادى ربه أني مسني الضر وأنت أرحم الراحمين فاستجبنا له فكشفنا ما به من ضر وآتيناه أهله ومثلهم معهم رحمة من عندنا وذكرى للعابدين وإسماعيل وإدريس وذا الكفل كل من الصابرين وأدخلناهم في رحمتنا إنهم من الصالحين وذا النون إذ ذهب مغاضبا فظن أن لن نقدر عليه فنادى في الظلمات أن لا إله إلا أنت سبحانك إني كنت من الظالمين فاستجبنا له ونجيناه من الغم وكذلك ننجي المؤمنين وزكريا إذ نادى ربه رب لا تذرني فردا وأنت خير الوارثين فاستجبنا له ووهبنا له يحيى وأصلحنا له زوجه إنهم كانوا يسارعون في الخيرات ويدعوننا رغبا ورهبا وكانوا لنا خاشعين.
I think we should start. So Dr. Sikandar is our first presenter, and I would request Dr. Sikandar to start his presentation.
Okay, thank you, Said, for invitation, and good evening, Evelyn. It's a long time to see you. So I will be talking the next 20 minutes about the management of DDH before walking age group. So I will be sharing my experience about how we are treating and what is actually the protocol. Actually, in Pakistan, we have got so many cases of neglected DDH. Most of the patients are diagnosed after the walking age because there is no screening program in Pakistan, and the condition is painless. So the parents just point out a limp after the walking of a child, and it's usually very late. So, but after the introduction of specialized care of pediatric surgery, because in the last 5 years, the specialty of pediatric orthopedic has grown too much in Pakistan. So now we are seeing so many patients at an early age group. So in early DDH, what we defined is a newborn up to 18 months of age. And we can have a child with a dysplasia only, subluxation, or a frank dislocation. As you can see over here, that is the frank dislocation, but you may find a patient with the dysplasia as well. So why we have to treat these patients early? Because this is a study which shows that if you treat a DDH before 1 year of age, so the final acetabular index, age maturity is usually very well if the DDH is treated before 1 year of age. But if you treat the DDH after 2 years of age, the ultimate acetabular index is usually not very good. And these patients then usually require reconstructive surgery early adulthood to correct their dysplasia. So it's better to reduce the hip early to have a better acetabular development. This is another study which shows that what will be the ultimate outcome if the hip is reduced early. You can see that these are the number of reconstructive surgery which is needed. So if I take an 18 months of age, you can see if the hip is reduced before 18 months of age, the chances of reconstructive surgery are up to 20%. But if the hip is reduced after 18 months, the chances of reconstructive surgery further in the adulthood will be up to 74%. So this is a lot of difference. So these two studies that they can show that we should reduce the hip early, and as you all know that reduction of the hip is usually if before 6 months of age, you may reduce it without any surgical intervention, and up to 18 months you may have a very minimal surgical procedure, because then the open reduction of a neglected DDH is usually through the anterolateral approach. That is a much more traumatic approach, and you may need to have a femoral as well as pelvic osteotomies in this age group as well, because my second and third speaker will be discussing these things. As I have said that we don't have any screening program in the Pakistan at the moment, but it is very important, which allow early detection of the significant hip dysplasia, which in turn permit early intervention and possible avoidance of surgery or future disability. So we can screen the child by clinical examination, periodical clinical examination, and selective ultrasound or universal ultrasound. So basically what we need to do, that we have to find out the high risk population, like the child, if a child is firstborn, it is a breech presentation, it is a female, or there is a positive history of the DDH in the family. So these are the high risk patients, and we should screen them to detect any hip dysplasia in this population. As I have told you that we don't have any screening program in Pakistan, but this is what in the Hong Kong, in the DKCH, they have a screening program for the DDH. What they do actually, that any newborn with the suspected DDH, it is clinically examined before discharge. Then they have to examine it at 1 month at the MCH center, and there is another examination at 6 to 12 months at the MCH center. And at any time, if they find out any abnormality, they will refer the patient to the pediatric orthopedic surgeon. If we find out a child with the DDH before 6 months of age, it can be very safely treated with a pelvic harness. So this pelvic harness, I check orthopedic surgeon in the early 50s, he actually treated the patient with his harness with a success rate of about 85% and an AVN rate of up to less than 3%. So what we do actually, that in a neonates, usually if you find a suspected DDH, so either there is a chance that you apply the pelvic harness early, or you can wait for 6 weeks before you can apply a pelvic harness, because in most of the patients who have got a unstable hip, they become stabilized by 6 weeks. But if at the 6 weeks, the patient has got any sign of hip dysplasia, he should be treated with a pelvic harness then. And up to 6 months, we can treat the patient very effectively with a pelvic harness. Now, this is very important, that how to apply the pelvic harness. We have to apply a chest straps, okay? And then we have to fasten the chest strap with the shoulder strap, and they have to be crossed on the back, so that we should avoid the slipping of the shoulder straps. And then we have to apply one anterior and one posterior strap. The anterior strap should control the flexion of the hip, which should be up to 100 to 110 degree. We should avoid flexion beyond 110 degree, because it will cause femoral nerve palsy. And the posterior strap should be in such a way, it should be fastened in such a way that it should prevent adduction of the hip beyond 20 degree. But one thing is very important, that you should not do a force abduction with the posterior straps. And then these are two straps around the foot. This is very important, that the proximal strap in the foot around the leg should be proximally fastened, because if it is too distal, it will cause bow stinging of the anterior and posterior straps, which will affect the abduction of the hip if these two distal straps are not properly fastened up. Now, the parent education is very important while you are applying the pelvic harness, because they have to remove the straps in the home for the cleaning purposes, and they have to reapply. Most of the time, we have to apply the pelvic harness for about 20 to 22 hours a day, so that they can be very effective. And abduction should never be forced. This is very important, that we should teach the parents that you shouldn't force the abduction by the straps while you are reapplying the pelvic harness, because it will cause AVN. So the protocol, there are different protocols for the pelvic harness. Different people are treating their hips differently in the pelvic harness, but this is one simple algorithm which they were using in the DKCH that clinically confirmed DDH. Usually they were confirming it with the ultrasound, and any patient with the alpha angle less than 60 degree, they were treating it as a DDH. So you will apply the pelvic harness for about 2 weeks, and then you will follow the hip in 2 weeks by an ultrasound. If the hip is not reduced by 3 to 4 weeks, then you have to discard the pelvic harness and you have to proceed to close reduction and with arthrography or open reduction through the medial approach. If there is a clinically reducible dislocation, then again you have to apply the pelvic harness. If the reduction is confirmed within 2 to 3 weeks, then you have to continue the pelvic harness for 8 to 12 weeks incomplete. And before discarding the pelvic harness, you have to do an X-ray in the harness and after that. So this is very important that we should follow these patients at least for 1 year of age so that we can see radiologically that the hip are mature. The success rate of the pelvic harness is about 80 to 95% in different studies. Some people have got a higher success rate while some have got a little bit lower. But the relative contraindication for the pelvic harness is that if the dislocation is very high, if there is a graph 4 dislocation, in the bilateral dislocation, the pelvic harness success rate is a bit low, or if the Ortolani test is negative, because when the soft tissue contracture develop, the Ortolani test become negative, then the pelvic harness may not be able to reduce the hip because it's a dynamic splint. For that, you have to have a positive Ortolani test. The pitfall for the pelvic harness is that the AVN rate is less than 20%. The femoral nerve palsy can occur, but if your flexion of the hip is more than 110 degree, and if the hip is flexed beyond 110 degree, then you have got a chance of inferior dislocation. And if the patient the hip is not reduced in 3 to 4 weeks, then you have to discard the pelvic harness. But for that, you need to have a very important teaching of the parents so that have a good compliance. Poor compliance is associated with the poor results. This is one of the study in which 115 hips with 115 patient with 130 hips were treated with the pelvic harness. The 40 years were the follow-up time was 14 years of age, and the overall satisfactory result were more than 90 degree. They have followed for the patient for 3 to 7 years. So if the patient is received after 6 months of age, or if the pelvic harness treatment is unsuccessful, then one has to go for the closed reduction and arthrography or open reduction through the medial approach. This is one protocol. I haven't followed this protocol, neither I have seen this protocol in the Hong Kong, that application of a traction before closed reduction attempt or an arthrography. But this is one modality of treatment that you can apply traction to for few days to 2 weeks before you can attempt a closed reduction. And this, they claim that this has got a incident of AVN can be reduced with this maneuver. Before we proceed to an closed reduction attempt under GA, we have to examine the hip, and we have to see whether the hip is reducible and what are the stability of the hip, whether the hip is relatively stable or not. So this will give you an idea that how will you proceed during your closed reduction attempt. Okay. This is a 14-month-old baby with a bilateral DDH. This was one of my patients. I did the arthrography in 2016, November 2016. Okay, so before any formal training in pediatric orthopedics, our practice in Pakistan was that we have to reduce the hip under image intensifier, and usually we get this picture. So by just this image picture, you can see that the hip is reduced. But we cannot say that this hip is concentrically reduced or not, because a concentric reduction is must for a good outcome. If the hip reduction is not concentric, so either this will redislocate or there will be residual hip dysplasia in the future. So I would not accept this reduction on just an image screen under GA. For that, you will do an arthrography through the medial approach. Okay, you will pass a needle, 22 gauge needle through the subadductor approach, and you will puncture the hip. You will make sure that your needle is in the hip joint. So this is my case. I pass a needle under the image intensified 22 gauge spinal needle, and I use a water soluble radio opaque dye. Okay, but before putting the dye into the joint, you have to make sure that your needle is in the joint, and for that you have to inject 1 cc of normal saline into the hip joint, and you have to see for the free flow of the normal saline distal water. If there is a free flow, this means that your needle is in the hip joint. This is another way of confirming the needle is in the joint. Air arthrogram. I did it only once for academic purposes. This was the only case I did an air arthrogram, that I inject air into the hip joint, and that also gives you an idea. You can see that your needle is in the hip joint. But the chances of air embolism are there. So just for academic purposes, I have done it once or twice, and then I usually use the normal saline. So what you actually see in the arthrography, that you can see all the soft tissues that can cause obstruction to the reduction. You can see this lower image. This is basically the inverted labrum. Okay, this is basically the very faint shadow of hypertrophic ligamentum teres. This is the pelvinar, you can see, and this is the constricted capsule, which is constriction is caused by the iliopsoas tendon. Okay, then once you are in the joint, you have put the dye into the hip joint, so you will move the hip in different direction. You will flex it, you will abduct it, you will internally rotate it, and you will assess the reduction. So what is the concentric reduction actually? The pulvinar should be everted. The medial pooling should be less than 4 millimeter. This is actually one of my patients. You can see this is actually a thorn sign. You can see that the labrum is fully everted, and the medial pooling is quite acceptable, and the hip is very concentrically reduced. So you have to assess the concentric reduction according to the criteria. Again, when you hip, this was in just flexion, and this was with internal rotation. You can see that the medial pooling has decreased a lot, and the labrum is everted. Then you can check the stability of the hip joint. That what is the stable position? You have to apply the spica in such a position that to prevent redislocation and to prevent the AVN chances. So I never force the hip beyond 45 degree of abduction. I usually give my spica in 45 degree of abduction. I hold the patient on the spica table, and my assistant, usually a very well-trained PG, he apply the spica to the child. You can do adductor tenotomy at the time of the close reduction if your adductor are quite tight. But most of the time, if the adductor are not tight, and you can safely move the hip from 20 degree to 60 degree of abduction. So this means it is a stable hip. So no need to do an adductor tenotomy, but never force hip abduction beyond 60 degree. You can see again another patient. This is a very inverted labrum. The labrum is lying in between the acetabulum and the femoral head, and this constriction is caused by the iliopsoas tendon. This is the patient in unreduced position. This was the patient in a reduced position, but still you can see that there is a lot of medial pooling. And this is the labrum. You can see this is actually not inverted, but what the Japanese call it as a blunted labrum. Again, the same patient, but I didn't accept this reduction. This was the best possible reduction with the hip flexion, abduction, and internal rotation. So if the concentric reduction is not achieved, or it is impossible, or there is a marked instability at the time of close reduction, then you can proceed in the same setting by open reduction through the medial approach. There are different types of approach. This is the anterolateral approach, you can see. But this is the medial approach. I usually use a medial approach in less than 18 months of age. But in addition to the age, there are some other parameters which you have to take into account by going a medial approach, because sometimes the patient is very, very fatty or floppy. So in those cases, you may not be able to go through the medial approach, or sometimes the hip dislocation is very high. So if it is a high dislocation, this means that the capsule will be very lax, so your reduction may be unstable because you can't do capsular FE in this through the medial approach. You can address all the obstacle except capsular FE. There are 3 different type of medial approaches. One in the Weinstein, in which actually it's the muscle plane through which you go. So in Weinstein approach, you go between the pectineus and the neurovascular bundle. The neurovascular bundle is lateral and the pectineus is medial. In the Ludloff, which was actually the prototype of the medial approach, in which you go through the pectineus and the adductor longus muscle. But in the Ludloff approach, the AVN chances in some studies it is very high. So the Ferguson approach was advocated, in which you go through the adductor brevis and adductor magnus, and you actually save the branches of the medial circumflex femoral artery in this approach. Again, the presentation of a different type of, in Weinstein, you go between the pectineus and the neurovascular bundle. This is the neurovascular bundle. In the Ludloff, you go between the pectineus is lateral, and the adductor longus and brevis, they are medial. And in the Ferguson, you go between the adductor brevis and the adductor magnus muscle. You can address all the obstacle through the medial approach. You can do a very good iliopsoas stenotomy, but the psoas tendon is cut very distal to such attachment. So the chances of weakening of the hip flexion is maybe a possibility in these patients. You can address the hypertrophic ligamentum teres, you can cut the transverse ligament, and you can clear the acetabulum from the pulvinar as well. Then you have to apply spica in the human position, 100-degree flexion, 40 to less than 60 degree of abduction, and the neutral rotation. And it should be well molded. So after close reduction, I usually apply spica for 3 months. Okay. In the Hong Kong, the protocol was that they used to change the spica after 6 weeks, do a second arthrogram, check the stability of the hip joint, and reapply the spica for again 6 weeks. But I haven't done it because of the workload and because of the other problems. We actually, the number of the patient is so much that we cannot change the spica at 6 weeks. So if the hip is reduced, we continue with the spica for 3 months. And after open reduction, I usually give the spica for 2 months. Okay. Very lax capsule, high dislocation, and children older than 18 months is a contraindication for the medial approach. One of my patient, 9-month-old male baby with the right DDH. This was his arthrogram. You can see that the labrum is inverted. This red line, inverted labrum, medial pulling is too much, and the hip is dislocated. I reduced the hip, but again, the medial pulling is a bit more, and the labrum is not fully everted. And even with the manipulation, I couldn't evert the hip, the labrum completely. So I proceeded with a open reduction through the medial approach, and you can see the hip is reduced, and this is in the spica. And this was his 12 months follow-up, a very good mature hip. Again, a 13 months old girl, I did it in 2016, bilateral DDH, left side open reduction in the February 2016, and right side open reduction in March 2016. Okay, in initial days when I started the medial approach, I was doing like this, that I used to do one open reduction at one time and other open reduction after 1 month. But academically, the medial approach is suitable for a bilateral open reduction in these cases. So if one has got an experience and one has got a team, you can do open reduction bilaterally. And the last, I think 2 to 3 cases in the bilateral cases, I did bilateral simultaneously. But in this case, I did it at 1 month interval. Now, the first open reduction, it was reduced, but see, now I am doing the CT scan at 1 month follow-up. And this is actually the advantage of a CT scan, that you can pick a dislocation very easily. So his hip was dislocated. One was reduced and the other was dislocated. So I proceeded for open reduction through the anterolateral lateral approach on the right side. This is the anterior shuntal line. This is how you assess the reduction of the hip on the CT scan. If the anterior shuntal line is intact, which is a line which passes from the anterior cortex of the pubic symphysis to the anterior metaphysis of the femoral neck, and if it is intact, so it is the hip is reduced. And if the line is broken, so you can say that the hip is subluxated. Okay, this was his 25-month follow-up. This was the hip, this one, which was the revision was done to the anterolateral approach, and this was the one in which we had a open reduction through the medial approach. Again, a 13-month-old boy with a bilateral DDH, a right open reduction in the March 2016, left open reduction in the May 2016. This is the X-ray in the spica. This is after the removal of the spica. Both hips are reduced, good position. And this is actually 24 and 22 months follow-up. On the right side, the acetabular index is 28, and on the left side, the acetabular index is 32. Actually, the left side was operated 2 months later as compared to the right side. Again, 17-month-old patient, left side has a closed reduction in one setting, while the right side had an open reduction. Left side, in which we were able to have a concentric reduction, but on the right side, the reduction was not good. So the right side was open simultaneously in the same setting. X-ray in the spica, and this is about 9 months post-op follow-up. Both are good, reduced, and mature. Okay, this is one case of patient female in which we had an open reduction through the medial approach, and she had a grade 4 AVN. Okay. But clinically the patient is okay. I'm still following the patient. I still cannot see the capital femoral epiphysis, but symptomatically the patient is asymptomatic, and she has got a very good gait as well. Very mild hip limp we can appreciate on walking. So let's see what happened to her. I am following the patient still. So this is just a study about the long-term outcome of the Ludlow medial approach. 45 hips in 43 patients were analyzed. Mean age was 14 months. Mean follow-up was 16 years. And the AVN rate was 30%, quite high. And it was especially in patient which was in the older age group, that is more than 17 months. Again, another study, 24 hips were operated with a medial approach. Mean age was 4.8 months. Mean follow-up 59 months. All cases were normal at the last follow-up. 2 patients required further surgery. 2 cases showed evidence of AVN. So they concluded that it is a safe approach for DDH in younger age group. Okay, this is our own data in the last 5 years. And one of our residents is now actually writing his dissertation for the fellowship exam in part 2 on the medial approach. And we operated 30 patients in the orthopedic department, Khyber Teaching Hospital, with a mean follow-up of 33 months. We had 1 case of AVN and 1 case of redislocation. 2 patients were not walking after 2 years, but their hips were reduced. Actually, this is another phenomena. You can discuss it, that those 2 patients, they were having a cerebral palsy. So you may all know that we cannot diagnose the cerebral palsy in 1 or 2 years of ages. Usually the spasticity appears quite late. But in those 2 cases, later on we find out that it was a case of those 2 were the cases of cerebral palsy. Their hips are reduced, but they were not walking, and their parents were very unhappy. Actually, they were thinking that the surgical procedure was responsible for not walking of their hip, although we wanted to console them that this is actually not the cause of the non-walking, but still, let's see what happened. Acetabular index was less than 25 in 20 hips, while 10 hips, it was more than 25 degrees. And we are still following the patients because our follow-up is not too long. We want to follow them for a longer period of time. Oh, thank you so much. This is an OR of the DKCH. Evelyn is there. Dr. Chavez, they were our mentor. Thank you so much.
Okay, thank you so much for thank you so much, Dr. Sikandar, for a nice presentation. Due to interest of time, we would take question in the end. So the next presentation is on walking age DDH, which is from 18 months to 6 years of age, and I'm going to present it.
Hello, Sikandar Saab. Yasser, somehow Saeed has lost his connection. I will take this opportunity to invite Dr. Evelyn Kong from Hong Kong, Duchess of Kent Hospital. Thank you very much, Evelyn, for being with us on this webinar. We had, all of us had a very difficult, unprecedented situation affected by this pandemic corona. So I hope that such type of webinar we shall be able to connect with each other and socialize to some extent, though such online webinar cannot replace face-to-face effective communication, but that is what we can do at the moment. Thank you very much again. I think you can share your screen and start your presentation, and we'll be back with once say the internet problem is over.
Hi, everybody. I'm Dr. Evelyn Kwong, coming to you from Duchess of Kent Children's Hospital in Hong Kong. Thank you, Dr. Saeed, for the kind invitation. I had the pleasure of meeting Dr. Sikandar several years ago back at Duchess of Kent Children's Hospital in Hong Kong. And over the years, I've met Dr. Saeed and Dr. Ali Abbas, and they've been great fellows of ours. But in the interest of time, I'll get straight to the topic. I'm going to talk about the management of proximal femoral growth disturbance and also residual acetabular dysplasia after the initial treatment of DDH. And I want to show you the Severin criteria because as pediatric orthopedic surgeons, we all want our patients to have good outcome after our treatment of DDH. And if you look at the literature, most people will establish type 1 and 2 as good outcome and type 3 and above as bad outcome. However, type 2 still means that there is some sort of proximal femoral deformity. And even though it is a good outcome, sometimes they still cause problems and still need surgical intervention. And this is what I'm going to talk about in terms of the proximal femoral growth disturbance. So the old term for this was avascular necrosis, but actually we're starting to move away from the term of avascular necrosis because the blood supply isn't permanently destroyed. In fact, it really is just some sort of disturbance to the way the proximal femur grows. And this phenomenon is always iatrogenic. In fact, you can get this after a Pavlik harness treatment or especially after our closed or open reductions. The most commonly used classification is Buchholz and Ogden, and there are 4 types. I'll go through each one of them one by one. Type 1 is a transient effect on the ossific nucleus, which means in the first year, the ossified part of the epiphysis of the proximal femur may disappear, but it always comes back within 1 year's time. So there's no surgical treatment for this. You simply wait and you observe. And if in 1 year's time the ossific nucleus comes back, there is never a permanent deformity in the proximal femur. Type 2 is the troublesome one. Type 2 is a lateral physeal damage, which means there's some sort of tethering at the lateral part of the proximal femur physis. And with time, you can see that the neck shaft angle will tilt into valgus. Or as you can see here, the physis will be tilted in a valgus direction. The problem with type 2 growth disturbance is that it can take up to 10 years for this to show up on your x-ray. So you may think you have a good outcome initially after your first surgery, but when the child suddenly becomes 10 or 12 years old, you will see that the neck shaft angle has gone into valgus. And this accounts for about 1/3 of cases of proximal femoral growth disturbance. And the way you treat it is like this. So I show you a 6-month-old boy who came to us with bilateral DDH. We did open reductions for him at the time. At 1 year of age, the right side looks pretty good. The left side still looks a bit dysplastic. Fast forward to 6 years old, you can see that both acetabulums are not remodeling quite as well as we want them to be. Both femurs are quite anteverted and also has a lot of valgus. So the way to fix this is to simply do a varus osteotomy of both sides. We did a varus and some derotation to both proximal femurs. And you can see another 3 years later, he's 9 years old now, and the neck shaft angle is much improved, and the acetabular remodeling is actually improving. And time will tell, but he looks that he is on his way to a good outcome. Sometimes you have a situation like this. This is a 4.5-year-old girl who presented to us with a dislocated hip. She was already walking by then, obviously. We had to do an open reduction, an acetabular osteotomy, and we had to shorten the proximal femur quite significantly, put it into a lot of varus and derotated it. And this is her at 4 years old when we did the first surgery, 5 years old, 6 years old, 7 years old, 8 years old. And you can see how the coxa valga develops with time. So even at the first surgery, when we thought we put her into a lot of varus, actually with lateral growth arrest, you can get a lot of coxa valga. And you can see how this will not be good for acetabular remodeling. But for her, she was very lucky in the sense that her acetabular remodeling still looked satisfactory, despite the fact that she had coxa valga. So what we did for her was the same principle as guided growth. We put a screw in to tether the growth on the medial side. And 2 years down the line, at least the neck shaft angle is not any more valgus, and the acetabular remodeling is still improving with time. So if you have a patient who has coxa valga, but the acetabulum is still remodeling satisfactorily, you just want to do something to prevent it from going to any more valgus, you can try this technique. Type 3 is when you have a central physeal damage and the entire proximal femur physis stops growing. You get coxa brevia. These patients have a lot of Trendelenburg gait. They have a lot of shortening of that particular limb. And so to fix these two problems, first you fix the Trendelenburg gait by transferring the greater trochanter distally. For this girl, we also did many other procedures, but you see that for the greater trochanter, we transferred it distally and we fixed it with 2 screws, and her Trendelenburg gait improved. Other methods have been described in the literature like this, with just a simple screw or an 8-plate or even a subtraction type of osteotomy. For me, I don't do these. I actually just transfer the greater trochanter distally, and that seems to have the best effect. And of course, you can do these fancy osteotomies, which fixes both problems at the same time, coxa brevia and coxa vera, but I've never tried this myself. And always remember that they have the second problem, which is Leyland discrepancy. So you have to give them a shoe lift for now, and of course, plan the epiphysiodesis at an appropriate time. The last type, type 4, is a medial type of physeal damage in which the patients get coxa vera. So you can see that her neck shaft angle is significantly reduced. They also have significant Trendelenburg gait, and they also have really markedly reduced abduction range because the greater trochanter runs into the acetabulum. So to fix this, you do the valgus osteotomy. But before you do the osteotomy, you have to do 2 things. First is you have to make sure that there is actually no more acetabular dysplasia. And second thing, you have to make sure that the hip will not sublux after you do your valgus osteotomy. So I routinely do 2 things. The first thing you do is you check the acetabular index and to make sure that you're happy with the remodeling of the acetabulum. If the acetabulum is dysplastic, then don't do the valgus osteotomy. The second thing I do is I actually screen them and bring the hip into full adduction, into full adduction in this manner. If the femoral head is still well seated within the acetabulum, then it's safe to do your valgus osteotomy. And this girl is very happy after the surgery. Her abduction range of motion has significantly improved, and there's less Trendelenburg gait. Another commonly quoted classification is the Calamchi-McEwen's. You can see that they describe the same 4 deformities, coxa vera, coxa valga, and also coxa brevia, just in a different sequence. But actually there's one more. If you talk about the disturbances to the growth of the proximal femur, there's also coxa magna, and this is quite commonly seen. Actually, after the surgery, there is an overgrowth of the proximal femur, as you can see here. The proximal femur, the femoral head, is much larger on one side than the other. And this will cause residual acetabular dysplasia. And the way to think about it is there is a massive femoral head, but with a tiny little dysplastic acetabulum. And there's no way for the acetabulum to remodel around this curved femoral head. The second thing it can cause is Leyland discrepancy. So you can see here, the femoral head is not much bigger than the other side, but you can see that the pelvis is tilted because this proximal femur has overgrown and it is too long. And when it is too long, your affected limb is always in slight adduction, and this will exacerbate any dysplasia you have. So to fix this, you have to do an osteotomy where you improve the acetabular coverage, but you can see here we also had to shorten her proximal femur to completely fix this problem. So as Dr. Sikander already noted, the rate of proximal growth disturbance or avascular necrosis can be quite high, up to 60% of patients treated for DDH. Unfortunately, the most common type is the coxa valga type. There are things you can do to avoid this, and one thing you can do, which is already mentioned, do not force the reduction, such as this 4-year-old girl here. You cannot simply stuff the femoral head back into the acetabulum. You must shorten it. If you do not shorten it, the pressures inside the hip joint will be very high, and they will be prone to developing proximal growth disturbance. The other thing, as also already mentioned by Dr. Sikander, you cannot force the immobilization in wide abduction or internal rotation. I always routinely cast my patients after a closed reduction or an open reduction in simply the human position. The human position means the hips are flexed 90 degrees and abducted 45 degrees with neutral rotation. If you find that you have to widely abduct the hip or add a lot of internal rotation to keep the hip inside the hip joint, then it is simply not good enough. You have to do further osteotomies to further stabilize that hip. And remember, as mentioned before in the first talk already, this can also happen in a Pavlik harness. This is one of the patients who defaulted follow-up and the posterior straps are simply too tight. So the baby is held in wide abduction. This will also cause proximal femoral growth disturbance. So back to our patients, how do you manage this? So as they're older, you have had your first surgery, but they have some sort of growth disturbance or residual acetabular dysplasia. How do you fix this? How do you fix this? Obviously, these cases are going to be very different. So there are a lot of things to analyze when you're thinking about an older patient who has residual deformity after initial treatment of DDH. And it's a lot of things, and we'll go through them one by one. The first thing I think about is whether or not the hip joint is still congruent. If it is still congruent and there is no osteoarthritis, then actually I will try to reconstruct the hip joint to improve the acetabular coverage of the femoral head and also to fix whatever residual proximal femur growth disturbance there is. So this is one example, and I'll go through the analysis one by one. The first thing I look at is the femur. So look at the proximal femur. What does the neck shaft angle look like? The neck shaft angle here is 149 compared to 140. It's a little bit more valgus, but not terrible. What is the length of the neck? Do I need to do a trochanteric transfer? Actually, the length of the neck is symmetrical compared to the other side. The anteversion, unfortunately for her, is quite significantly anteverted. You can screen that clinically and also on your x-ray. And also she has some leg discrepancy. The right leg has overgrown a little bit. So you can see for her, the proximal femur has some anteversion problems, is significantly anteverted, and the right lower limb is too long. Okay, that's the femoral side of the problem. What about the acetabular side? You do a false profile view to look at the anterior coverage. Normally, your anterior coverage should extend all the way out to here on the femoral head. For the right side, for the affected side, the acetabulum only covers to about 50% of the femoral head. So there's loss of anterior coverage of the acetabulum. You abduct the leg to see how much you need to abduct. Say this is 25 degrees, 30 degrees, for you to properly cover the lateral coverage of the femoral head. So when you do your osteotomy, you fix all of those problems. On the femoral side, we shortened her. We also did a derotation osteotomy. On the acetabular side, we did a triple osteotomy, and we improved the lateral coverage and also the anterior coverage. This is another example. Residual acetabular dysplasia and uncoverage when she is skeletally mature. On the femoral side, it's actually quite good. The neck shaft angle is quite comparable to the other side. The length of the neck is good. There's no significant femoral anteversion. It's symmetrical to the other side. And the leg length is a little bit longer than the left side, but she was quite happy with this. What about the acetabulum? On your false profile views, you can see that the anterior coverage is very deficient. Normally, the anterior coverage should come all the way out to here on the femoral head. For the affected side, it only comes up to 50%. Same thing, when you abduct the hip by about 30 degrees for this patient, now you have adequate lateral coverage of that femoral head. So we did a periacetabular osteotomy, and we took this fragment to improve the lateral coverage and also the anterior coverage. And this is a pre and post-op view to show you how the anterior coverage has improved after the osteotomy. What if the hip joint is already incongruent, but fortunately there is no osteoarthritis? Then anything you do now is simply a salvage osteotomy, a salvage procedure which lengthens the longevity of the hip joint, but is actually not going to be a normal hip. So this is one example. This hip joint is not congruent. You have a nice big round femoral head, but the acetabulum is very shallow and very flat and very small. And this is kind of how I look at it. It's a big round femoral head, but a very tiny hat sitting on the side of the femoral head. So this is not congruent. There's no amount of derotation or redirectional acetabular osteotomy that I can do for it to sufficiently cover this big round femoral head. So the proximal femur is quite normal. The neck shaft angle is normal. There is mild coxa brevia, but she does not have significant Trendelenburg gait, so we left it. There's no significant anteversion problem, and the leg lengths are the same on both sides. It really is a problem with the acetabulum, with the lateral coverage, and also the anterior coverage of the left hip. So we simply gave her a shelf procedure to improve the lateral coverage and also the anterior coverage. This is another example. This is a slightly younger patient. She was 9 years old. You can see this is definitely an incongruent hip joint. The femoral head is round, but the acetabulum is completely straight. And she is too late for a reshaping osteotomy like a Dega. So the proximal femur is significantly anteverted and has coxovalga. Sometimes we do a CT scan to better visualize the neck shaft angle and also to better visualize the anteversion of the proximal femur. And of course, the acetabulum is very dysplastic, very insufficient acetabular coverage anteriorly and also laterally. So for her, we did a shortening, varus, derotation osteotomy of the proximal femur. And because the acetabulum is too incongruent, we simply put a shelf there. And many years later, actually it looks promising. It looks like the femoral head is well covered, but you can see that the hip joint space is actually very narrow. This is actually not a normal hip, and she does have some mechanical pain on prolonged walking after several hours, but she knows that she will get an arthroplasty later on in life. And actually her right hip is also dysplastic, but it's congruent, so we will do a periacetabular osteotomy for her next month, in fact. What if there's already osteoarthritis? Well, for these patients, if they're still very, very young or they have a very high functional demand, then you can do a hip fusion. This is a very unfortunate 13-year-old boy, so he's very young. He had many, many procedures done at another institution and finally referred to us. You can see that he clearly has no more cartilage in that hip joint. He has very severe mechanical hip joint pain, and so the only option left for him was a hip fusion. If you have an older patient who has a lower functional demand, then arthroplasty is the mainstay of treatment. So this is a 40-year-old lady who had a good left hip after an acetabular osteotomy, but the right side already has florid osteoarthritic changes. And she is a 40-year-old lady with grown children, and she has a clerical work, so she has a very low functional demand, and she ended up with an arthroplasty, and she's very happy with her hip joint. So there are a lot of things to consider when you're talking about the older DDH patient with residual deformity after surgery. One way to look at it is just simply look at the congruency of the hip joint first. If it's still congruent, then it's still salvageable. You try to do some sort of reconstructive surgery like this. If it's already incongruent and there's nothing more you can do for the acetabulum to reshape or to redirect it, then anything you do is a salvage procedure such as a shelf procedure. If already there is osteoarthritis, hip fusion has a very limited indication in our hands. Most of our patients will receive a hip arthroplasty. And so that's how you think your way through in an older patient with DDH and residual deformity. Thank you for listening, and welcome to any of you to come visit us in Hong Kong. Thank you for inviting me.
Thank you, Evelyn, and we will entertain question and answer at the end of our presentation. So I guess Saeed is over his network problem. So Saeed, are you ready?
Yes, sir. I am ready. Can you see my presentation on this?
Yeah, I hear you clearly and I can see your slides clearly. Please go on.
Okay. Bismillahirrahmanirrahim. So my talk is management of walking age DDH from 18 months to 6 years of age. This is the place where I did my training. It's a Gurki hospital, and I did my fellowship from in pediatric orthopedic with Dr. Wang Chow and Dr. Evelyn Kwong in Hong Kong. And recently I am working in Peshawar Medical College. So these are the contents of my presentation. So first I'm going to talk about the development of the normal hip joint. And I think it's important in decision making. Then I would talk about how to achieve a tension-free reduction and how to achieve a concentric reduction and maintaining a reduction. I think that's important to prevent complication like dislocation and proximal femoral growth disturbance and acetabular dysplasia, which has already been discussed nicely by Dr. Evelyn Kwong. So as acetabular physis and its growth, so acetabulum is lined by an epiphyseal cartilage, and between the epiphysis and between the epiphysis and the pubic bone, there is between the pelvic bone, there is a physis, which normally we cannot see on X-ray. And the growth of this physis is essential for the normal development of acetabulum. And damage to acetabular cartilage may induce growth disturbances. And acetabular dysplasia will occur if there is any damage to the superolateral part of the cartilage. So this superolateral part of the acetabulum is very important. And what happened is, because it's very commonly practiced even currently in Pakistan, that people usually pass K-wire for maintaining the reduction through the greater trochanter and the superolateral part of the acetabulum. And ultimately, the child land up with acetabular dysplasia. So this should not be, so the superolateral part of the acetabulum is very much important and it should not be damaged. Now, coming to the late development of the acetabulum, the majority of the acetabular shape is determined by approximately 8 years of age, and older DDH, there is a lesser chances for the acetabulum to remodeling. So that is also important in decision making. Now, coming to development of the femur, the primary ossification center in femoral head appears at around 4 to 7 months of age, and greater trochanter ossification center around that appear at around 3 to 4 years. Any insult to the femoral head growth center will lead to proximal femoral growth disturbances, which was already discussed by Dr. Evelyn. So it's important. Now coming to femoral anteversion, at birth the normal femoral anteversion ranges from 40 to 60 degree, and it decreases with age, and at 16 years of age it's normally becomes 16 degree. And hip extension is the main force for the normal development of the anteversion. And most of the DDH patient, they do not have delayed milestone, they have normal milestone. So there is a normal development of the femoral anteversion. And I think this is important, because if we are operating on a younger child, like around 2 years or below 2 years, so the anteversion would be high and derotation will improve the anterior coverage. But in the older child, like 3 years and above, then derotation will risk the posterior dislocation, especially if we combine it with the capsulorrhaphy and pelvic osteotomy. This was a phenomena explained by Dennis Wenger, as you all can see in the figure on the right side. So there, if we combine a Salter osteotomy with a derotation and capsulorrhaphy, so we must be very, very much careful, because otherwise it will end up with the posterior dislocation. So now coming to development of the neck shaft angle, at birth the neck shaft angle ranges from 140 to 160 degree, and it decreases with age to 130 degree. So abduction is the main force which decreases it. And in DDH, the neck shaft angle almost develop normally. So if we add 15 to 20 degree varus, it will improve the lateral coverage in DDH and it will remodel. But it's important that with the age, the remodeling potential of the varus osteotomy decreases. So we must be very much careful if we are dealing with a 5 to 6 years of age DDH. So we must carefully produce a varus, because exaggerated varus, it may not remodel with time and will lead to proximal femoral growth disturbances. Now coming to obtaining a tension-free reduction, it's very important for the normal development of the hip joint, and obtaining reduction is difficult in walking age because the femur is proximally located most of the time. There's contracted iliopsoas and adductor and contracted inferior capsule. And tension-free reduction is achieved by adductor and psoas stenotomy, inferior capsulotomy, femoral shortening, and varus osteotomy to prevent tension of the abductors. Now, maintaining a concentric reduction is also very important. It's because if a reduction, obtaining a concentric reduction is also very much important for the normal development of the acetabulum. And these are the structures like ligamentum teres thickened out and it's become longer, the limbus become inverted, the pulvinar become hypertrophied, and there's a contracted transverse ligament. And all these structures, we must address all these structures to obtain a concentric reduction. So excision of ligamentum teres, hypertrophic pulvinar, and transverse ligament, these all should be addressed, but we must preserve the limbus. Previously, in older days, if the limbus was too much hypertrophied, people used to excise it. And this practice should not be done because it may lead to acetabular dysplasia. So now coming to maintaining a stable reduction. Difficulties in maintaining a stable reduction, like a redundant superolateral capsule, neck shaft angle, increased neck shaft angle, the femoral anteversion, acetabular dysplasia, and abnormal acetabular anteversion. So maintaining a stable reduction can be achieved by excision of the redundant capsule, doing a proper capsulorrhaphy by transferring the superolateral part of the capsule to the inferior part, and doing a pelvic osteotomy and varus derotation osteotomy. Now coming to femoral shortening plus varus derotation osteotomy. Femoral shortening is very much important. It's a substitute for traction. It reduces risk of AVN and redislocation. But at the same time, if we do simple femoral shortening, it stretches the abductors and may cause dislocation. So that's why it's important that we should give a 15 to 20 degree varus, which will improve the lateral coverage and it will decrease the tension and abductors, and thus we will achieve a tension-free reduction. Now, this was a patient operated elsewhere. This was, I would call it as a poor technique because the reduction is forceful. The surgeon tried to maintain the reduction with bypassing a K-wire, and the reduction is non-concentric, and the surgeon is hoping that he will get a good result. So poor technique, it's always that we should maintain tension-free reduction. Our reduction should be concentric, and our reduction should be stable by doing a capsulorrhaphy, femoral osteotomy, and all the structure. And then in the end, I would talk about the pelvic osteotomies. So in the walking age between 18 months to 6 years of age, mainly three. One is the redirection, that is Salter osteotomy is commonly performed, and the other two, the reshaping osteotomy, which is a Dega and Pemberton osteotomy. Salter osteotomy, it is usually performed between 2 to 6 years of age, and it starts from just above the anterior inferior iliac spine and straightly goes into the greater sciatic notch. And then it is displaced anterolaterally, and the hinge is formed at the symphysis pubis. The problem with the Salter osteotomy is that as the child gets older, so it is difficult to produce correction in it, and the maximum correction we can achieve it is about 10 to 15 degree. Now coming to Pemberton osteotomy, it also starts above the anterior inferior iliac spine, and it directly both laterally and medially goes into the triradiate cartilage, and we produce a hinge at the triradiate cartilage. The beauty of this osteotomy is that it's a stable osteotomy. Most of the time we do not need any graft for fixation. We do not need any K-wire for fixation, and it's a stable osteotomy, and it gives more correction, but it should be done mostly in those patients who have very high acetabular index. Otherwise, because it slightly decreases the size of the acetabulum. Now coming to the Dega osteotomy, it forms, it's a very good osteotomy, and in the Dega osteotomy, the hinge also form at the triradiate cartilage. It also starts from above the anterior inferior iliac spine, and it goes posteriorly and slightly curved. But it's an incomplete osteotomy, and the posterior medial part of the iliac bone is kept intact. And depending upon the type of coverage, if we want to achieve, like in neuromuscular patient like cerebral palsy, if we want to achieve a posterior coverage, so we place the graft posteriorly. And if we want to achieve an anterolateral coverage like in DDH patient, so we have to place the graft anteriorly, and it will give the coverage like a Pemberton osteotomy. Now, after doing a DDH, obtaining a concentric reduction, then we apply a spica cast. It depends, it varies from center to center, but most of the time in my practice, I apply spica cast for 6 to 8 weeks and then convert it into abduction cast at 4 weeks. And I usually follow the patient 3 monthly for 2 years, then 6 monthly till maturity. And on each visit, we measure the acetabular index, the location of the femoral head, the proximal femoral growth disturbance, and Shenton line, and development of the teardrop and sourcil. This is the sourcil. Now, this is a child who presented at a 2-year, 6-month-old girl, and she underwent Salter osteotomy plus femoral shortening and capsulorrhaphy. In the beginning of my practice, I was trained by Dr. Chirag, and Dr. Chirag Saab usually favor of not doing a varus osteotomy. He likes only femoral shortening, and most of the time he also do not do a derotation. So no derotation was done, and then it's a 3 year, 6 months post-op, and the patient is now 7 years old. The femoral head is well covered, although it shows some signs of proximal femoral growth disturbance. The teardrop is well formed, the acetabular index is well corrected, and it's developing normally. The sourcil also is showing signs of normal development. But we have to follow till maturity for any proximal femoral growth disturbance. Another patient, 2 year, 4 months girl with bilateral DDH, and I did a bilateral VDRO plus DEGA. First, I operated the left side, then after 6 weeks, operated the right side. Unfortunately, actually, I did a DEGA, but I didn't get a proper femoral graft for the osteotomy side, so I have to fix it. Usually, most of the time in DEGA osteotomy, we do not need a fixation. So this is a 1 year, 6 months after, and now after removal of implant, the femoral head are well covered, the Shenton line is maintained, the sourcil is developing well, but I have to follow the patient till maturity for any growth disturbance. These are my references. Thank you. Over to Dr. Harun. Sir, I think we can take questions from the audience at the moment.
All right, okay. Participant, if there is any question, you can raise your hand when we can unmute your mic and you can ask a question, or you can post them in the chat box. So Malik Iqbal Sahab has raised his hand.
Thank you very much, Saeed, and thank you very much, Dr. Kwong and Dr. Sikandar. I'm really grateful. There's a good webinar going on. I just wanted to ask all of you about, especially about the children who we operate and under late age. They do develop some limp afterwards. And how long does limp last? In your experience? And and they do have some stiffness as well in the hip. And just with ordinary physiotherapy and walking, will it go away, or do we need to do anything more with that?
I suppose I can try to answer a little bit first. The reason why you see so much limping in the older child that we do DDH surgery for is because, as the first three speakers have already talked about, you always end up having to shorten quite a lot, and to also build in some degree of varus into your proximal femur to reduce the hip back in for an older walking patient with DDH. And those two things will give you abductor insufficiency, and so these patients will get a limp. The problem is it does last for quite some time. And in fact, a lot of these girls will end up having a limp for up to 1 year, even 2 years. But it does improve with time, and they do adapt with it quite well. Physiotherapy certainly does help, and we routinely refer them to physiotherapy. But you're right. Unfortunately, in some of them, it still persists maybe after 1 to 2 years. But that's just something that I've noticed. Dr. Sikandar, do you have any input?
Thank you, Evelyn. Actually, we in Pakistan, we are seeing the neglected DDH cases a lot. And in Hong Kong, I had never seen a DDH patient beyond 3 years of age. If you remember, when I came to the Hong Kong, there was a girl lying in the ward with a 3 years of age, and you were very worried that how in Hong Kong she was left to be operated for DDH for 3 years. But this is a routine for us in Pakistan. We routinely have if I get a child with a 3 year, I am very happy that we got it early. So till 3 or 4 years of age, when we do a triple procedure and we use the spica for just 2 months, and then for 1 month abduction cast, so that we can make her mobile very early. So in those patients, they are usually very well. Their gait is quite normal by 6 months or at most 1 year of age. But we receive patients who are 6 years or 7 years or even 10 years of age with a DDH. And Bhatti Sahib is there. We discussed the cases with him as well. We usually operate on these patients, although the literature doesn't support, because we know that we wouldn't have any normal hip in these patients. But at least we reduce it, and we would like to have a near normal hip, that whenever the patient undergoes a total hip replacement in her future life, so she will have a relatively easy primary hip replacement rather than doing a very difficult primary hip replacement.
Right.
And even with the, as Saeed Saab was saying, with Professor Chirag, we have even operated on patient with the 20 year of age with a DDH by colonosteotomy. So here again, the main problem is the stiffness. The stiffness is always there in these older age group. And at most, we are able to receive, we are to achieve a hip flexion of up to 90 or 100 degree. So what I do actually, that by at 1 year of age, I usually remove the femoral implant. So at that time, if the stiffness is there, I do a very gentle manipulation of the hip as well to improve the hip flexion. Said, do you want to say anything?
Yeah. Regarding the stiffness, I would say what I learned in Hong Kong is that even when I saw Dr. Chow operating his revision cases, and it's a dissection, I think, which is very much important. In Pakistan, I would say that the biggest achievement which I have done is that when I work with Dr. Chow, it's a dissection which has improved a lot. And if we do a proper dissection, if we identify the structures properly, and if we give time to the surgery, I think the chances of stiffness then become very, very less, especially if we are operating below 5 or 4 years of age patient. It's not only the spica which gives a stiffness to the patient.
So Dr. Asif Pracha has raised his hand.
As my question is all from all speakers, that what is the cause of AVN other than forceful reduction? Any other risk factor we lead to AVN other than this forceful reduction? Obviously, forceful reduction is a well-known factor. What are the other causes or other precautions we should take to prevent this AVN?
So as I said in my talk, the first is the forceful reduction. The second is how you immobilize the child after your reduction surgery. So after our closed or open reduction, we typically give them a hip spica. If you abduct the hip by more than, say, 50 or 60 degrees, and especially if you have to add a lot of internal rotation, and if you immobilize a child that way in the hip spica, they will get proximal growth disturbance. And this is because the blood supply to the epiphysis runs along the retinaculum, the hip joint capsule, around the posterior aspect of the hip joint. So you can imagine if the blood vessels are the posterior aspect of the femoral neck, and you widely abduct and you also internal rotate, that will actually physically compress on the blood supply to the proximal femur, to the femoral head. So you should never do that. What sometimes happens is in a very young child and you're attempting a closed reduction, say you do an arthrogram as Dr. Sikander described, and you think you've got a good concentric reduction, but you find that you have to widely abduct the hip or have to add a lot of internal rotation to keep the hip in a well-reduced position, you should not simply immobilize the child in that position. If you have to widely abduct the hip and add internal rotation, that means there are more osteotomies you have to do. You probably have to add an acetabular osteotomy to improve your coverage. You probably have to derotate your proximal femur so that it's not so anteverted, so you don't have to internal rotate the hip so much. So actually, Dr. Chow and I, our rule of thumb in Hong Kong is after whatever procedure you do, closed reduction, open reduction, osteotomies, you have to be sure that if you immobilize a child, we are only abducting the hip to 45 degrees and there is no rotation. So flexion 90 degrees, abduct 45 degrees, and neutral rotation. If you find that you have to add more to keep the hip in, then you're not done with your surgery. You have to do more before you can immobilize them in that position. So we routinely force ourselves to immobilize a child in the simple human position, which has no rotation and no abduction more than 45 degrees. And if you can do that, then the AVN rate will be much lower.
Dr. Arun, I think we should take our last speaker. Instead of Professor Atiq Saab, Dr. Umair Nadeem is going to present.
Yeah, okay, we can do that.
Hello everyone, I hope you can see my screen. I'm Dr. Umayyanuddin, consultant orthopedic and spine surgeon at Turkey Trust. I'm part of the faculty of pediatric orthopedics under the leadership of Professor Chirag and Professor Atik Usman. This is Professor Atik's talk, but unfortunately he is currently having an international meeting right at the moment. So I'll be giving it on his behalf. Our topic is neglected high riding DDH after 8 years. So basically we are going to discuss some of the preservation and salvage options in DDH. We all know that after 3 years of age, permanent structural adaptive changes occur within the hip joint and developmental dysplasia. And after 8 years of age, acetabular dysplasia has very little potential to remodel. So in such cases, to preserve the native hip and to avoid pain and to have long-term preservation of the hip, one can do one of the available preservation or salvage procedures. We divide these procedures into distinctly two different groups. The first group are the patients with residual dysplasia but potential congruence. These are the patients in which a congruent hip joint can still be achieved with cartilage to cartilage apposition with a certain osteotomy. Various options include the triple inanimate osteotomy of the stele and the Bernese periacetabular osteotomy of the gans and pericapsular dial osteotomy of the acetabulum of upright. I'll be briefly discussing them. The in Steele's osteotomy, you do a series of cuts in ilium, ischium, and pubis, and the purpose is to reorient the acetabulum over the femoral head to achieve cartilage to cartilage apposition. Acetabulum is repositioned and stabilized with bone graft and pins. The other option of salvage is Gans periacetabular osteotomy. It creates a free acetabular segment through a series of osteotomies in ischium, superior pubic ramus, and ilium by preserving the posterior column of the pelvis. The advantage of this periacetabular osteotomy of the Gans is that the posterior column remains intact and the patient can avoid spica and can start weight bearing earlier. The other group is patients with residual dysplasia in which there is no potential congruence remaining. So it means that cartilage to cartilage apposition cannot be achieved. Either the acetabulum is very dysplastic or small and the head is very large. So what one has to do is that we do one of the salvage procedures, which could be shelf procedure with slotted acetabular augmentation of Staheli or a Chiari osteotomy, which is the capsular interpositional arthroplasty. And another novel procedure is Colonna's capsular interpositional arthroplasty. I will briefly talking about. And shelf procedure, slotted acetabular augmentation is carried out to produce a congruent acetabular extension. A slot is created just above the capsule, and a graft is placed. And with the help of reflected head of the rectus femoris tendon, we can stabilize this graft. The capsule that is interposed between the femoral head and the graft then undergoes metaplastic change to a fibrocartilage. This increases the head coverage and reduces the acetabular dysplasia. Another option is Chiari's osteotomy. It is a capsular interpositional arthroplasty, which means that there is medial displacement of the acetabulum with the help of an osteotomy that starts just below the anterior inferior iliac spine and moves feller 20 degrees upwards. The acetabulum is displaced medially and the lateral part of the ilium comes to rest over the capsule and the femoral head. The capsule that underlies between the iliac bone and the femoral head then undergoes change into the fibrocartilage with weight bearing, and then it reduces the dysplasia and pain. The basic purpose is to improve the hip biomechanics and reduce the limb. The Chiari initially recommended this osteotomy for untreated developmental dysplasia after the age of 4 years. However, the current consensus is to perform this osteotomy in painful, non-congruent hips after 10 years of age. Another procedure we used for hip salvage and preservation in the adult DDH is Colonna's capsular interpositional arthroplasty. It was historically described but was largely abandoned. The interest has been re-invoked by Gans et al. The purpose is to preserve the native hip and postpone the total hip arthroplasty. What we do is that we do a surgical dislocation of the hip, and we divide the capsule from the acetabular rim. The capsule that is so achieved is then wrapped over the acetabulum just like this. And with the help of acetabular reamers, small reamers, we create a cavity or a space in the acetabulum with the help of reamers. And this hip and with the covered capsule is then reduced into the created acetabular slot, just like that we do in total hip replacement. This capsular tissue then undergoes metaplasia into the fibrocartilage, and you can have hip preservation. We started doing this procedure 4 or 5 years back. Initially, we published a series of 6 cases, but currently we have a series of 26 cases for this procedure. I will show you some of my cases now. This is a 10-year-old female patient, pre-op radiograph. You can see a neglected DDH with a very dysplastic acetabulum, pyrided cartilage almost close to closure, and a small femoral head. You can also appreciate a false acetabulum forming here. We did Steele's triple pelvic osteotomy and stabilized it with wires and femoral shortening. And this is 6 months post-op. You can see the acetabulum has been reoriented with cartilage to cartilage apposition over the femoral head. This is 2 years follow of the patient. You can see an appreciable acetabular remodeling still possible. And patient is quite pain-free. You can see her spotting. This is her video 2 years down the line with triple pelvic osteotomy. This was our article on one-stage hip reconstruction for the development of hip dysplasia in children over 8 years of age. It was a retrospective series with 77 patients, 77 hips and 65 patients. Average age was around 11 years. These patients underwent Steele's triple pelvic osteotomy, Salter osteotomy, and the results were evaluated on modified McKay scoring system and Severin scoring method. 22 patients had 28.6% patient had excellent results, and 57.1% had good results. Results were poor in about 2.6% of the cases. This is a patient with bilateral neglected DDH, 11 years old female. Salter osteotomy was done on one side and double pelvic osteotomy was done on the other side. You can see there is some remodeling with this procedure, but growth disturbances can be appreciated on the both sides. However, the function of the patient improved and the pain also improved. This is an example of the patient with shelf procedure. You can see a 12-year-old female with dislocatable hip and residual acetabular dysplasia and a painful hip. This is how we do the shelf procedure. We create a slot in the upper part of the just above the capsule, and the graft comes to rest at this level, and this is cancellous graft, and this is then covered with the tendon of rectus femoris. This is I'm sharing our paper on capsular arthroplasty for neglected developmental dysplasia of hip, that is the Clona's procedure. This was a series of 6 cases, and we judged the patient again on the modified McKay scoring system and Severin scoring system. All patients had excellent outcomes according to this scale, and post-op Severin classification was 1A in all of the patients. We have been performing these patients since then, and now our series is that of 26 patients, and we are going to publish them again. This is a 22 years old male patient with a neglected DDH. Colona's capsular interpositional arthroplasty was done, and you can see the 2 years of follow-up. You can see the maintained joint space because of fibrocartilage formation derived from the capsule of the hip joint. You can see the range of motion at 2 years. Another patient with Colona's capsular interpositional arthroplasty. Now, this is a very interesting case I will be discussing in the last. This was a young software engineer, 22 years old female. She had painful hip on the both sides, and you can see coxa magna and hip dysplasia on the left side, and proximally dislocated femoral head with high dislocation of femoral head, and a very shallow acetabulum. So we did hip preservation surgery in this patient. First, we did the Chiari's osteotomy on the left side, and you can see the 5 months follow-up osteotomy is healing. And then this is what we did after first year. We did colonus capsular interposition arthroplasty, surgical hip dislocation, wrapping of the capsule of the femoral head, and this acetabulum has been recreated with acetabular reamers. You can see pre-op how shallow and slanting this acetabulum is. But with the help of acetabular reamer, we created this slot, interposed the capsule, and did a femoral shortening. We had to put in this wire because she was adult and quite obese patient. So for early head stability, we had to put this wire. I did this procedure in the start of this year in January, and this is her follow-up, just recent follow-up in August 2020. You can see the carry-off shortening was done by Professor Ateek more than 1 year back. The patient is completely pain-free on the left side, and also now you can see the remodeling of acetabulum, not exactly remodeling, but recreation, reincarnation of acetabulum with the help of colonus procedure. You can see there is some space. It is not very congruent, but the patient has quite a good function, and according to her, the pain is markedly improved. She has some abductor lurch as of now. This is just her video 2 weeks back. She is walking. She doesn't complain of any pain. The range of motion is good on both sides, but we are having her rehab done and muscle strengthening now. So, take-home message is preserve the hip, drawing all means. Hip arthroplasty is actually the amputation of hip, and it can be done at any time, even after hip preservation surgery. So why not to give the patient a chance at hip preservation and to preserve the native hip? Thank you.
Thank you very much. So to the panelists, there is a question posted in the chat box. How do you handle leg length discrepancy after a successful treatment of DDH?
So it's after DDH surgery, it's important that we follow the patient. If we operate it below 5 or 6 years of age, most of the time they do not develop LLD. But if they develop LLD, then we have to manage it the same way like how LLD is managed in other children. Like we measure the LLD, we can try epiphysiodesis just 2 years before completion of their growth, and at the same and if the LLD is which is less likely to occur if the hip is well reduced. If the LLD is too much, we can go for the other options as well, like lengthening, or sometimes you can do a opposite side femoral shortening. So there are multiple options, but the most commonly, if they develop an LLD of more than 2 centimeter, and if the growth age remaining is up to 2 years, then we can simply do epiphysiodesis of the opposite side.
I also have to make a comment on this. If the patient develops limb discrepancy problems, another very good option is periosteal stripping. You can do a periosteal stripping at proximal femur, at distal femur, and distal tibia and fibular level. And there is literature available on it. Yeah, that at a timed procedure can also help deal with the LLD in the younger patients.
I just wanted to. No, I just wanted to add one point is that for the younger patients, if you end up with a hip that is actually a little bit shorter than the contralateral side, so if the side with DDH after your surgery is a little bit short, about 1 centimeters or even 2 centimeters, actually I leave it. I don't treat it, because I know that keeping the hip a little bit short is good for the acetabular remodeling, because your pelvis tilts in such a way that it's well covered. In fact, if the overgrowth phenomenon happens and you get coxa magna, then that's when I worry, because the side affected with DDH is now too long, and your pelvis will tilt in such a way that your hip is always relatively adducted, and this will actually make the dysplasia worse. So I'm usually more concerned with overgrowth, and if there is overgrowth and the DDH limb is too long, I treat it aggressively with a shoe raise when they're still very young, and then as Dr. Saeed says, I plan the epiphysiodesis when they're later. If it's an older patient, for example, if it's already a teenager or a 20 years old, and the DDH is that the limb with the DDH is slightly short, about 1 to 2 centimeters. Actually, again, I usually leave it. I don't do anything because eventually, when these patients do have an arthroplasty later on in life and in their adulthood, the arthroplasty surgeons can make up for around 2 or 3 centimeters of length. So I don't aggressively treat shortening of the limb by, say, lengthening or anything like that. At most, I will do an epiphysiodesis, and I will leave it on the short side, 1 to 2 centimeters. In fact, it's advantageous for them that way.
So thank you, Evelyn, and thank you, Dr. Sikandar, Dr. Umair, and Dr. Said for taking out time and joining our webinar. We are just approaching the time, and there is an announcement for our next webinar. This is about systematic review. Introduction, part 2, part 1 has been done a couple of weeks ago. Would like you to contribute more in our next webinar. Thank you, everybody. Thank you very much. Goodbye.
Thank you, Harun sir.
Thank you.